Well, thank you for being here and for the opportunity to present. I'm Joe Gleeson. I'm at the University of California, San Diego, and I'm Chief Medical Officer for n-Lorem. And the way I got involved was I was at some early talks on the success of nusinersen for spinal muscular atrophy, which is a disease that I saw a lot in clinic. And it was so exciting to me to see a technology that could be used and could really save lives. I called up Stan, and I started to interact a bit with Ionis, and he told me about this new foundation that he was starting. I initially started to volunteer, and then my involvement became more over time. So now I'm involved in the medical aspects of what n-Lorem is doing, and I'll tell you a little bit about that, and tell you about how we make the decisions, about how we make the recommendations, I should say, about risk-benefit, to assess the risk and the potential benefit for these individual patients. These are some of my disclosures. One thing that we deal with a lot in genetics, so my background is in child neurology and genetics, is that we've learned over the last 20 or 30 years or so, is that most of the genetic mutations that have a big effect in humans are very rare. And that's at the top left corner, the red ones. The ones that are at top right, common variants that have a large effect, those are very uncommon. There's not a lot of variants like that, maybe ApoE, a couple of these things. But for the most part, we're dealing with rare variants that have a large effect. That means we are stuck with lots and lots of individual genes. There's no blockbuster drugs, we've learned, for child neurology, at least for the most part. And for these single gene disorders. And that's why a technology like ASOs that can scale for individual patients is so exciting. And what we've learned from studying genes over time is that there's now more than 7,500 individual syndromes, essentially. These are the number of genes that cause unique conditions. And you can see how that's grown since 2000. Kind of when I got involved in this field. How do we make 7,000 unique drugs? It's very difficult to do if you're a small molecule, but ASOs, I think, have a very important role because they're programmable, and a lot of people in the field are recognizing the potential really to change outcomes across many hundreds or even thousands. And there are 7,500 of these individual conditions that affect tens of millions of patients worldwide. So, like many of the physicians in the room, we see patients with rare disease. 300 million patients in the world have a rare disease. 50% of those are children. And it takes, on average, each of those patients will see 8 different doctors while they're getting their diagnosis. And 70% of these patients are misdiagnosed. And 40% of them are misdiagnosed more than once. Maybe some of you in the room have had this experience. It's not very pleasant. And then it takes 8 years or so to come up with a molecular diagnosis. And we hope that time will come down as we have more access to genome sequencing. And so we think of this patient lying in the bed as, the genome is being done, it gets into a computer, and then the important work is done by a team of doctors called clinical geneticists. They're still kind of the black box for us in our field because they have to interpret that genome, the billions of bases, and decide if a mutation is pathogenic or likely pathogenic, and if it's not, they categorize it down in the benign group. n-Lorem can only deal with mutations that are in the pathogenic or likely pathogenic. We're very reliant on the clinical geneticists because we can only make drugs that others in our medical community have decided are causing disease. And so after receiving a genetic diagnosis, a lot of families pursue several paths, and probably several of you have been down these paths. The first thing you do after you get a pathogenic or likely pathogenic mutation, your doctor will probably sit down with you, you discuss it with the medical team. A lot of times those interactions are not very satisfactory because that doctor may not have ever seen another patient with this genetic condition before. And so often families go home with this genetic diagnosis and they search the internet and they find and sometimes the internet is hopelessly misleading, I'm sorry to tell you, but sometimes there's some gems there. You might connect with other families if you're lucky enough and learn as much as possible about that gene. Sometimes this is a new gene, there's not anything known, and that's what lead a lot of families to develop, their family support groups and then pursue precision medicine. And many families find us taking this journey. Not very many, you heard maybe 300, but there's hundreds of millions of patients. Where are the other hundreds of millions of patients? We don't really know. At this point, they're on this journey still. They're going to contact you that lead family support groups when they get their diagnosis, and then eventually they're going to hopefully make their way to us or to other kinds of precision medicine approaches. And I think that this paper, you probably all are familiar with Mila from Tim Yu, published a couple of years ago, really opened the door for this kind of precision therapy. I mean, many of us in genetics were thinking, wouldn't it be great if we had treatments for these rare diseases? And Tim really opened the window for that opportunity, where this patient had this genetic mutation. There was a drug that was developed just for her called Mila, and she had a unique mutation that, although it was a loss of function, the mutation actually activated a splice site. So it was a gain of splice that led to a loss of function, and that paper really kind of was the starting flag for what we're all trying to do right now. And you all know about what n-Lorem is doing, the mission. And one thing I wanted to mention, we deal a lot with at the ATTC, is when is the right time to consider treatment? We've all heard early is better. That's probably true. But what we need to measure is a delta. And a delta is the difference between the outcome if there was no treatment and with a treatment. And the promise of precision medicine is that we can impact the outcome in a measurable way so that people will believe us. There's a lot of skeptics out there. Earlier treatment has the potential to lead to a bigger delta. Because we can intervene earlier, we can have a better measurable effect on the outcome. There's some conditions like ALS where it could be very difficult. Either they're very slowly progressive or we don't know the best time to treat. Other conditions like where there's a very slow progression, so measuring those deltas can be very difficult, and we have to be ready for that. The approach to treatment in general, at least, I spent a lot of time in medical school thinking about mechanisms of disease and things like this, but it all boils down to this with ASOs. It's very simple. If you have a mutation that is a loss of function, we have to somehow reactivate that gene. And if it's a gain of function, we have to somehow inactivate that gene, turn it off. ASOs can do both of these things. It's easier to target the gain of functions, and that's why most of our programs are targeting the gain of function mutations, but we're making a lot of progress now on the loss of function mutations. I'll give you some examples of those. So there's three main ways that the ASOs work. This is from a paper we published a couple of years ago. We looked at all the mutations in the patient database in ClinVar and figured out which ones could be treatable with ASOs. ASOs can work on loss of function mutations by upregulating the remaining copies or paralogs, as Stan mentioned. It can work on haploinsufficient conditions. That's where one copy is missing, like by targeting poison exons and a couple of other examples I'll show you. And finally, these toxic gain of function mutations, we can knock them down. So we're hoping for a future where the clinical geneticists can really be partners, where they read that DNA sequence and they don't just say this is a likely pathogenic mutation. They say, hey, n-Lorem has a drug for this already. This is the mechanism of this mutation. Or maybe it's not n-Lorem, maybe it's some gene therapy company or something like this. But right now, we're waiting for the molecular geneticists to really step up their game so that they can fill that really important void. The pathway for n-Lorem, you probably have, I think maybe someone showed this slide already, so I'll just go over this very quickly. I'm going to really focus on what ATTC does, because we have the doctors at the tertiary care center, they apply. ATTC's Access to Treat Committee. We carefully evaluate the risk-benefit ratio, and I'll tell you how we do that. Eventually, when it leaves ATTC as approved, it gets into the drug development, what Nadine was talking about, and then eventually patients are dosed. So we deal with three main mechanisms, as I've mentioned. We have splice gain mutations. These are mutations that turn off a gene because they activate a new splice site. We have splice switch mutations where we want to avoid splicing to an exon. They're like this one with the red flag in the middle of it because it's a bad exon. And we have these toxic mutations. The ASOs can target those and turn them off. I want to show you a couple of example nominations that we have to open the window, the thinking that we do at the ATTC. And I'm really privileged to work with so many amazing people on ATTC. This is the current roster, and most people join every meeting. It's really amazing. These are all eminent physician scientists at academic medical centers across the US and one from Canada, and represent many different subspecialties across medicine, and many are pediatric specialists, some are adult specialists, and all this knowledge is brought to every single nomination, many decades of experience, and this is how we make the recommendations whether a given patient should be accepted to the n-Lorem program. So what would be the perfect situation is it would be a nomination like this, where there's already amazing mouse data that shows an ASO works. So this was a Dravet syndrome, which is a really severe epilepsy. This paper was published in 2020, and they gave a single dose of an ASO at P14, that's 14 days after birth, and normally almost every mouse would die. That's the red line at the bottom right. And with a single dose, basically every mouse lived. That's amazing. I mean, you don't see that kind of data, a death versus life with a single dose. In this instance, the ASO targeted a bad exon, the exon that has that red stop sign that we call kind of a poison exon. We don't have this kind of data for most of our nominations. It would be wonderful if we did. This would show us that there's a really good potential that an ASO can impact the natural history of disease. What we've been able to do is really surveying the literature very carefully and making our best guess as to the risk-benefit ratio based upon the existing literature for each gene. So we've had over 300 applications submitted to date, as Stan mentioned, about 140 different drug discovery programs to date, 20 INDs and 4 divisions of the FDA. And you can see how these progress. These are their current status. The ATTC actually has a hard job, but it's actually not very hard when you think about it, because all we're doing is evaluating the patients, making our best guess as to the risk-benefit ratio, and then passing it on to the people that develop the drugs. So this is one example of a nomination, and I want to thank Cedric, who puts all this data together. This was a patient that was nominated with a mutation in a gene called MYT1L, and this is the mutation. It's a K at the amino acid 60E that presented with intellectual disability. We don't have the photo of the patient because these are all kept blinded to the team. But what we do, the first step is look in the database, and what we use is OMIM. And this is the OMIM entry, and you can see there's one entry for this gene, and that is for an intellectual disability disorder type 39, and it's a dominant. AD means autosomal dominant inheritance. And so could we think about treating this patient with an ASO? The parents were hopeful, the doctors were hopeful, they didn't know. They nominated the patient to n-Lorem. What we do is look in the published literature. So this was a genotype-phenotype paper that was published on this gene a year or two before we got the nomination. So we pulled the data up, and what we found was that this missense mutation, this K60E that the patient had a very similar clinical presentation to many patients with stop codons. And the red here are all truncating variants. So this told us that this mutation, this K60E, likely turns the gene off, that copy of the gene off. And ASOs had no way to upregulate the healthy copy. So unfortunately, in this patient, this nomination, although it was desperate situation, we had to decline until there's more research done. And when we got back to the doctor and the family and said, unfortunately, there's just not enough information for us to proceed. The risk is greater than the potential benefit of making an ASO. That was an unfortunate, situation. We have a lot of examples, though, where we're able to, the risk-benefit ratio is favorable. So In this patient here, this is a gene POLR3A. And this patient has leukodystrophy. That's a white matter disease. And this is the MRI scan. Perhaps you can see the white matter is not normal on the MRI scan. And this is an autosomal recessive condition. You can see the inheritance as AR. This gene leads to this leukodystrophy hypomyelinating type 7. We're not able to accept a lot of recessives. And the main reason is because recessives are mostly loss of function. ASOs are not easy to turn genes back on. In this instance, we were really fortunate because we looked very carefully at the mutation. These are the two mutations that were read by the clinical geneticist. One of them was inherited from the father. That's that F849L that was called likely pathogenic. And the other one from the mother. And that is a T596 equal sign. Equal means it didn't even change an amino acid. And so the clinical geneticist called it as a VUS, a variant of unknown significance. But we looked at it very carefully. Said something very interesting about that mutation because, and you can see it there in the bottom in yellow, it creates a cryptic splice acceptor that looks just like the normal cryptic splice acceptor, a CT. On the right, that mutation changes a C to a T. So we think this creates a splice gain. And that's magic for us because ASOs are great at changing splice sites. So that became what we thought was initially going to be a decline to a potential accept. We got back to the doctors. They're doing some more follow-up work like some RNA-seq to help us understand if this could be an ASO amenable approach. So splice gain, this is the same basic mechanism that Mila had. She had a splice gain in an autosomal recessive condition, and ASO was able to correct the splicing. We're hopeful in that example that we can correct the splicing. It won't work for most of the patients with that gene, that POL gene, but a small subset. And this gets to what Stan was talking about. Each patient is really kind of its own experiment. If we can show that an ASO can provide clinical benefit, then there'll be a lot more motivation to think about treatment for the vast majority of other patients with that gene. This is a patient, hope you don't mind me presenting, Margot. Okay. This is a patient that's 14 months of age that has an SCN8A mutation in epileptic encephalopathy. And she had age of onset of symptoms was 3 months with really intractable epilepsy, infantile spasms, tried many medications without any real major benefit. No other organs are involved. And SCN8A, if we look in OMIM, we see there's 4 different conditions. And that's because there's many individual mutations. They each can produce a slightly different phenotype. And she had one of the most severe types, which is this developmental epileptic encephalopathy. And what was quite unique about her mutation, if you don't know this story, is that she has a mutation in one of the exons called 5N. And when this gene is assembled, it either uses 5N or 5A, but never both. So it splices from 4 to 5 to 6. Her mutation is in 5N, and so and it's an S217P mutation. So the question was whether we could splice switch to use 5A instead of 5N. So it's another example of a use of an ASO to basically change the splicing, but that's going to remove the effect of that mutation and should normalize the function of that protein on channels, on the channels. It's a sodium channel mutation. Another example is we've heard about this gene already, NARS1. NARS1 is a gene that is involved in tRNA synthetase, so it puts the amino acid arginine on the tRNAs. And there's 2 different conditions in OMIM, almost exactly the same phenotype, but one is recessive, autosomal recessive, and one is dominant. And this was strange. How can there be 2 different diseases, 2 different inheritance patterns for the same gene? It doesn't really make a lot of sense for geneticists. Most genes are either dominant or recessive inheritance. This one has both. How can there be 2 different zygosities for the same clinical presentation? These are the MRI scans here of patients that have this condition. This is at 2 years of age and 5 years of age. So it seems to be a progressive condition. So what we found by reading the literature is while most of the NARS mutations are recessive, loss of function, there are a few very specific mutations that are dominant, gain of function. and this was a genotype-phenotype paper from 2020. The red boxes are those very rare de novo mutations that are toxic gain of function. And those are ASO amenable. So the patient has one healthy copy and then one toxic mutation. If we can use an ASO to turn off the bad copy, their cells should have normal function with the healthy copy that remains. And the reason we know this is because the parents of those patients that have the recessive mutations are fine. So that de-risks the program for us. And that's the example of the toxic mutation. So what we try to do at ATTC is weigh the risks and the benefits. So we have the expected risks, and then we have the potential risks. And we don't know the potential risks. We have to kind of estimate them by looking into the future. We have the expected benefits, and then we have the potential benefits that we just don't know. For instance, Olivia's patient, we didn't know the boy was going to start to walk. That wasn't even on our radar. That's a, unexpected benefit, a potential benefit, but kind of unexpected. And so we have to weigh the risk and the benefit for each patient. It's really tough to do this because there's a lot of unknowns, but we have this amazing team on ATTC, and I'm really proud of all the work we've been able to do in evaluating these hundreds of nominations we've had over the last couple of years. So to conclude, there's treatments for patients with these untreatable diseases, and we're hoping that the molecular geneticists can really step up their game to help process this, and so we can really industrialize this process. It's really important that we look at the mutations, we understand the mechanisms, and we spend a lot of time on the phone with basic scientists at universities around, really around the world, saying, hey, would you mind doing a couple of experiments for us? We think this patient could qualify, but we're just missing this key piece of information. And literally every time we call, those doctors are happy to help. I think it's probably never had an example where the doctors are not willing, because they've been studying this gene, in their little microcosm, and then someone calls them up and says, hey, we have a potential treatment for this gene you've been studying in worms or flies, for 20 years. And I'm like, yes, definitely, I want to help. And that's been so gratifying. So those are some of the most exciting experiences that we have. So I'll just conclude there and like to thank all the members of the n-Lorem team listed here, and you've heard from all of them already. So thank you so much.